Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Upstate is accredited as a regional pulmonary embolism center of excellence, and today I'll be talking with two of the physicians who are dedicated to the care of patients with pulmonary embolisms. Dr. Michael Costanza is Chief of Vascular Surgery and Endovascular Services at Upstate, and Dr. Manju Paul specializes in pulmonology and critical care. Welcome to the Informed Patient, both of you.
Thank you for having me.
Thank you.
This accreditation comes from the PERT Consortium, which began with a team of physicians at Massachusetts General Hospital. PERT stands for Pulmonary Embolism Research Team. In general, what did Upstate have to do or show in order to be accredited?
We had to go through a whole process of demonstrating that we had a multidisciplinary team that was able to respond quickly to patients with pulmonary embolism. And that involves several disciplines, which we can talk about, but it basically involves having this team on the ready 24 hours a day so that when a patient gets diagnosed with a pulmonary embolism, the team responds. We quickly triage the patient into what type of therapeutic care they need, and then we deliver that care so that we waste the minimal amount of time in getting them definitive treatment for their pulmonary embolism.
What are the specialties that are part of this multidisciplinary team?
Specialists from multiple disciplines to perform rapid risk stratification and formulate individualized treatment plans for complex PE patients. Our team at Upstate comprises specialists from pulmonary critical care medicine, emergency medicine, interventional radiologists, vascular surgeon, interventional cardiologists, and cardiothoracic surgery.
Well, help us understand what a pulmonary embolism is. How do you go about explaining it to family members, Dr. Paul?
A pulmonary embolism is a blood clot that has traveled to your lungs. Most often, these clots are formed in the deep veins of the legs, and then they break off and travel through the bloodstream into your lungs, where they get stuck and block the blood flow. And this causes your heart to work harder to pump blood through the lungs.
So, Dr. Costanza, what causes the blood clots to develop in the first place?
Well, there's a variety of things that cause a blood clot to develop. Usually it's the confluence of several factors that come together. The high-risk things that happen are patients that have had surgery, or patients that have had a recent traumatic injury, or people that have had prolonged bed rest, or you've heard of people taking long plane flights. Sometimes after sitting on a plane for many, many hours, they get up and their blood is clotted in their legs. It's usually a variety of things that come together, those risk factors, plus the patient being slightly dehydrated or maybe a little sick, and they come together and they form a blood clot. So that's what usually happens.
Are there symptoms that a person would experience? How would they know that they have a blood clot?
The typical symptoms of a blood clot in the lower extremities are swelling. Usually it's painless swelling that would tip them off. If the blood clot did become a pulmonary embolism, like Dr. Paul said, it would travel to the lungs. And the typical symptom of that is to have abrupt onset of shortness of breath, or feeling like your exercise tolerance is just suddenly decreased, where you weren't getting out of breath when you were going upstairs before, but now you really struggle to get up the stairs. And so that could be a symptom of a pulmonary embolism.
Dr. Paul, who is prone to develop these clots or deep vein thrombosis?
The deep vein thrombosis risk increases exponentially with age, and gender can affect DVT risk differently across your lifespan. So women have a higher risk during their reproductive years, usually between 20 and 40 years of age, due to pregnancy, being on oral contraceptives or hormonal therapy, while men have higher risk at older ages, usually beyond 65 years. And when you exclude pregnancy and estrogen-related risks, in general, men have approximately twice the risk of women overall in developing venous thromboembolism. And like Dr. Costanza mentioned, there are certain strong provoking factors, such as major surgery, especially after an orthopedic surgery, patients who have active cancer, any kind of prolonged immobilization, any major trauma, or even hospitalization for acute medical illness can account for approximately 60% of all the venous thromboembolism cases that we see. And there are certain chronic conditions that can predispose you to developing thromboembolism, such as inflammatory conditions. Obesity is a major risk factor. Patients with chronic kidney disease or heart failure, patients with antiphospholipid syndrome, and certain inherited thrombophilia, such as factor V Leiden deficiency or prothrombin gene mutations. They account for about 5% of the DVTs that we see. And smoking does significantly increase your risk for developing thromboembolism, history of varicose veins, or even having a personal or family history of thromboembolism puts you at a higher risk of developing DVT.
Dr. Costanza, if you have a patient that has deep vein thrombosis, are you able to predict how likely it is that that'll develop into a pulmonary embolism?
Well, we're not able to predict with a lot of precision, but we do know that patients who have DVTs that go up from their legs, their femoral veins into their pelvic veins are at much higher risk than people that just have clots that are below their knee. You can imagine that as we get closer to the heart, the veins get larger. And so as your clot gets into the larger veins, the likelihood that that clot can travel and have significant consequences if it does increases.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Michael Costanza and Dr. Manju Paul from Upstate's Pulmonary Embolism Center of Excellence. Let's talk about how embolisms are treated. What happens when a patient arrives at Upstate with a suspected pulmonary embolism? Dr. Paul?
So once patients come in with symptoms suggestive of pulmonary embolism, the first test that they get is a CT angiography, and that would confirm if the patient has pulmonary embolism. And once that's confirmed, PERT can be activated in patients who have hemodynamic instability or patients with submassive or what we call intermediate risk PE with evidence of right ventricular distress or strain, or in patients who have large PE or what we call saddle embolism. And in certain complex cases, such as pregnant patients, patients who've had a major surgery, or patients who are at a high bleeding risk. So in all these situations, PERT is activated. Now, who can activate PERT? This can be the emergency physician or a hospitalist or an intensivist. And once PERT is activated, the PERT fellow, who's the medical ICU fellow on call, would evaluate the patient and risk stratify the patient based on a lot of criteria, looking at the clinical data from the patient, which is the patient stable hemodynamically? Is the patient requiring medication to support the blood pressure? Is the patient requiring oxygen? We also review imaging data, which would be the CT scan of the patient. These patients also get a bedside ultrasound to look at the right heart function for any evidence of RV strain. And we also look at the laboratory workup, such as cardiac biomarkers, their coagulation profile, the hemoglobin and platelet, which helps determine if these patients are at high risk for bleeding. We also use certain risk scores, such as the PESI score, which predicts their 30-day mortality from pulmonary embolism. And based on all this data, patients are classified into high risk, intermediate, or low risk pulmonary embolism. And depending on what risk they fall into, if it's a low risk PE, the patients end up getting anticoagulation and they're closely watched in the hospital. Patients who have high risk or intermediate risk PE, this is where we have a rapid multidisciplinary discussion, which is done in real time to review the patient images and all the other data to come up with a consensus recommendation with regards to what treatment pathway would the patient benefit from. And broadly, the treatment pathway we use are either continuing anticoagulation in patients who have hemodynamic instability or who are in shock, recommending systemic thrombolysis. Patients with intermediate risk PE, catheter-directed interventions can be considered. And in certain situations where patients are in cardiac arrest or in refractory shock, ECMO can be provided to these patients. Surgical embolectomy is something that can be offered to patients who fail all of the above treatments, which would be catheter-directed treatment or where systemic thrombolysis is contraindicated. Once the treatment plan is established, the PERT team efficiently mobilizes all the resources that is needed, such as moving the patient to either the vascular lab or the IR suite, or the OR or bringing them to the ICU for close monitoring.
So, Dr. Costanza, can you describe what a patient looks like who's having a pulmonary embolism when they arrive at the emergency department? Are they typically conscious?
Well, like Dr. Paul said, it all depends on the severity of the embolism. So it can range anywhere from completely asymptomatic and something that's just picked up during the CAT scan in a patient with a DVT to somebody who is literally in shock and requiring CPR and anything in between. That's why it's so important to have a team like this where if we have a suspicion and then we scan them and we find they have a PE, that we give them the appropriate treatment for their level of severity as quickly as we can. Because when you look at pulmonary embolism, it's one of the leading causes of hospital-based death in this country. And that's why we all do this.
Are they easily confused for something else? Could you think it's a heart attack or an asthma attack, and it actually turns out to be a pulmonary embolism?
Yeah, they can be confused. The nice thing about our modern medicine is that we have such ready access to scanners that we can quickly make that differentiation. And then that's why we can have these rapid response teams, because we have the ability to make these diagnoses with a quick scan that just takes a few minutes, and then we can mobilize the proper treatment team.
One of the treatments that Dr. Paul mentioned was anticoagulation. And I'm just wondering, we've talked on this show with stroke experts and they use the clot busting medicines. Do you guys use the same things?
Yes, we use the same thrombolytic or the clot buster medication that is used for ischemic stroke and also for patients with MI. So the one that's commonly used is alteplase, which is FDA approved for acute PE. And the dose is slightly different from what is given for patients with acute stroke. We use a higher dose, which is 100 milligrams over 2 hours, as compared to a maximum dose of 90 milligrams for patients with acute ischemic stroke. The difference in the dose is basically related to the difference in the pathophysiology and the clot burden that we see in the disease process. The recovery from pulmonary embolism is extremely variable. It can take anywhere from weeks to months. Radiographic resolution of the clot can be seen as early as 7 days to a couple of months. The resolution, it's faster in patients who have peripheral clots as compared to patients who have significant consolidation or other pathophysiology that's going on. And despite the complete resolution that we see radiographically, about 50% of the patients still have persistent symptoms of dyspnea and decreased exercise tolerance that can be seen up to 1 year.
So they may still have trouble breathing and they may still feel like they're having a pulmonary embolism?
Yes, some of these patients can actually continue to have symptoms beyond the 3 months. The recommendation is to treat these patients for 3 months with anticoagulation, but it's not uncommon to see that patients can have prolonged symptoms. And it's been referred to as post-PE syndrome, where these patients have persistent shortness of breath and dyspnea and decreased quality of life. And in about 1 to 3% of PE survivors, we see a condition called chronic thromboembolic pulmonary hypertension. And this is a serious condition because this carries a mortality of 25 to 30% if not treated.
Once the immediate danger has passed, what does the follow-up care look like for these patients once they go home from the hospital?
Follow-up care after PE and DVT, it involves a lot of key components: monitoring anticoagulation efficacy and safety, and assessing for any persistent symptoms that patients might have, and screening for what I mentioned, chronic thromboembolic pulmonary hypertension. So guidelines recommend that these patients have a follow-up visit in 3 to 6 months to ensure that they are adherent to their anticoagulation therapy, and also to make a decision as to when can the anticoagulation be stopped in these patients. If patients continue to have persistent symptoms, then the guidelines recommend that these patients should get an echocardiogram to look for evidence of pulmonary hypertension. And if there is a suspicion that these patients could have chronic thromboembolic pulmonary hypertension, then additional testing need to be done, such as a VQ scan, because these patients may benefit from being referred to a CTEP specialized center, because a procedure called surgical thromboembolectomy can actually be curative in these patients.
Dr. Costanza, is a person who survives a PE at increased risk for another one?
Yes, anybody who has a DVT and a PE is always going to be at increased risk compared to the average patient for having another thrombotic event. Now, most patients, it will be a very, very low risk, but if they get into situations which are also risk factors, like if they have orthopedic surgery or if they're laid up or in bed for a while or go on a long flight, they just have to be aware that they are at elevated risk compared to the average person in those situations.
Well, that's good to know. I want to thank both of you for making time for this interview.
Thank you. It was a pleasure being here.
Thank you for having us.
My guests have been Dr. Manju Paul, who specializes in pulmonology and critical care, and Dr. Michael Costanza, who oversees vascular surgery and endovascular services at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.